Today we're going to talk a little bit about motor neuron disorders as well as disorders that affect peripheral nerves, including sensory and motor neuropathies. So this is a picture of the corticospinal tract. I'm not going to go over this in too much detail because you have other lectures that cover this topic, but I just wanted to point out the upper motor neuron starts in the motor cortex. It traverses down through the midbrain, all the way through the pons, crossing over in the lower medulla before it ends on the the lower motor neuron in the spinal cord. So this is just another picture looking at the lower motor neuron. So you can see the motor neurons are located in the ventral horn of the spinal cord. They exit through the ventral root and then they join with the peripheral nerve that then innervates the specific skeletal muscle. When the lower motor neuron activates the skeletal muscle, then the skeletal muscle will contract. So depending on where you lesion in the motor system, you're going to get two separate findings. So you've got the upper motor neuron, which is part of the corticospinal tract, that comes all the way down from the cortex all the way through synapsing at the lower motor neuron in the spinal cord, and then the lower motor neuron, which then exits the spinal cord to synapse on the muscle. So if you lesion the upper motor neuron anywhere along the corticospinal tract, you're going to have weakness, but you're not going to have wasting of the muscle. So that's kind of a sign that this might be an upper motor neuron lesion. So the muscle remains intact. You're going to have something called spasticity or increase in tone, which means that when you try to move the affected limb, you get resistance to passive movement. This is velocity dependent, so the faster you try to move that limb, the harder it becomes to move. You also get brisk reflexes or something called hyperreflexia. So when you test the reflex, you get an exaggerated response than what you would get in a normal reflex. You can also have something called primitive reflexes, which also are a sign of hyperreflexia. One example of this is a Babinski sign, where if you scratch the bottom of the foot, the toes extend. This is not normal. They should flex unless you're talking about a neonate, and then they do have a positive Babinski where the toe can go up, which can be normal. Which is why it's called a primitive reflex, because it can be present in the beginning of life. When you lesion the lower motor neuron, so this is anywhere from in the spinal cord where the lower motor neuron is present, all the way out through the ventral root to the spinal nerve, then to the peripheral nerve, you're going to also get weakness, but this weakness will be accompanied by muscle atrophy. So you need constant innervation from that lower motor neuron into that muscle to maintain muscle mass. So when the muscle is no longer innervated by that lower motor neuron, you're going to have atrophy, and those skeletal muscle fibers become atrophic. You have low tone or flaccid tone, so there's a decreased resistance to passive movement, and you're going to have absent or reduced reflexes, which is also called hyporeflexia. Because those muscles, those skeletal muscle, is no longer innervated by the lower motor neuron, you can see something called fasciculations, which means that there's some hyperexcitability, there's been nerve damage, so you get this spontaneous movement of individual skeletal muscle fibers. It can look like just twitching underneath the skin. It's not a big enough movement to kind of move the affected joint, but you can just see it kind of like creepy crawlies underneath the skin. One example of this would be, which is a normal fasciculation, if you've had too much caffeine, if you haven't had enough sleep, if you're under stress. So basically anytime during medical school, if you have some twitches in the eyelid, that's a fasciculation, but that's a normal fasciculation. So when we think about motor neuron diseases, the most typical motor neuron disease is amyotrophic lateral sclerosis. It's the most common acquired motor neuron disease. And this affects both upper and lower motor neurons. So this is the hallmark of ALS. So patients will have upper and lower motor neuron lesions, or upper and lower motor neuron signs, often occurring in one limb. So you'll have hyperreflexia and atrophy in the arm, for an example. Patients can also have cognitive decline. They have a frontotemporal dementia picture, which is something that we'll talk about in a later lecture, but it can include other things other than the motor neuron system. However, the hallmark really is the atrophy of the corticospinal tract. So you have average age of onset is about 56. There are slightly more men than women affected. The average length of illness from symptom onset to death is about 3 years, and most patients will die from respiratory failure because respiratory muscles are under voluntary control, so they're under control of the corticospinal tract. When you lose the innervation to the diaphragm and the accessory muscles, you can no longer oxygenate. So a lot of these patients will end up on mechanical ventilation to survive. So the clinical picture of ALS is that typically you'll see symptoms occurring in one limb or one myotome. So a myotome is a specific group of muscles that are innervated by a specific spinal cord segment. So all of those muscles that are innervated by that specific part of the spinal cord will be affected. And you'll have upper and lower motor neuron signs in that specific limb. Often ALS can be patchy, so you'll have symptoms or signs in contralateral limbs, so you'll have one leg and one arm affected, and so you'll know that it's not just one specific region of the spinal cord that's being affected, but it often will start in one part of the spinal cord and then spread. It can also begin in the cranial nerves or the cranial nerve motor nuclei. This is called bulbar onset ALS, and it's not as typical as limb onset. These patients will have symptoms of swallowing problems and slurred speech because bulbar means the part of the motor system that's innervated by the lower brainstem, so tongue, pharynx, those parts of the musculature involved. These patients have a poor prognosis because as their swallowing is affected, they're more likely to develop a pneumonia, but it's also the more rare of the two forms. So the genetics of ALS are pretty well studied. 2/3 of familial ALS and 10% of sporadic ALS can be explained by genetic mutations. Now, the one that you need to know for step 1 will be SOD1. That one might be tested, but it's actually not the most common gene. The two most common genes are the C9orf72 and the TRDBP mutation. That one's actually the most common. So the diagnosis of ALS is really made first by clinical presentation. So you've got to have presence of upper and lower motor neuron lesions in a limb or in a spinal segment that then progresses over time. This can also be helped with, or the diagnosis can be corroborated with an electromyography and nerve conduction study. So you don't need to know the details of this, but electromyography tests muscle fiber activity and innervation from the lower motor neuron. So if you, like we talked about with fasciculations, you may see hyperexcitability of those muscles. So what the test actually looks at is the electrical activity within the muscle itself. Nerve conduction studies actually check the velocity of the nerve. So you stimulate the nerve at one point and you test how long it takes to get to a second point down the limb. And any damaged neuron is going to be a little bit slower, and there's specific patterns that can be more easily identifiable with demyelinating versus axonal lesions. So this can be helpful in distinguishing between the two. So this is just a quick slide on the pathology of ALS. I'm sure that you'll get more information on this from lecture by Dr. Poole. However, I just wanted to mention quickly. So these are just some slides showing the pathology. So in slide A, you can see the spinal cord section showing the atrophic anterior horns and demyelinated corticospinal tract. In segment B, D, and E, you can see TDP43 inclusions, which is one of the protein pathological hallmarks of ALS. Ubiquinin inclusions are also pathognomonic for ALS, so TDP43 and ubiquinin, those are the two abnormally accumulated proteins that are involved in ALS. So there's only one FDA-approved medication for ALS at this time, and that is riluzole. The mechanism of action is not very well known, but in clinical trials, what occurs is that patients have a longer period of time before needing mechanical ventilation. So patients who didn't get the drug compared to patients who did get the drug, they were able to delay mechanical ventilation by about 3 months. So not a lot of time, but better than nothing. So this is what all patients with ALS typically receive. Patients also need supportive care, so this is anything from social work help to set up the home with patients who are developing progressive weakness to inserting a gastrostomy tube to help with feeding and nutrition. And then you can also not forget supporting the caregivers because this can be very burdensome for them as well. So when you see a patient who you are suspicious of having ALS because of findings of weakness with possibly some other neurological signs, there are a few things on the differential. So the first is something called multifocal motor neuropathy. This disease is different because it only involves the lower motor neurons, so you'll only have lower motor neuron signs. However, it can be very patchy. So similar to ALS, you can have, the right leg being involved and then the left arm being involved. So you can tell that it's maybe patchy. It's not just involving one specific segment of the spinal cord or one specific peripheral nerve. So this is a demyelinating disorder as well. So you can tell the difference between this and ALS using a nerve conduction study. And these patients will also be GM1 antibody positive, so it can be treated with autoimmune therapies. Cervical cord compression is also something that you need to be thinking about. This can produce lower motor neuron findings at the level of compression and upper motor neuron findings below the level of the lesion. So if you think about how that works, is that you're compressing the corticospinal tract within the spinal cord, so anything below that level is going to have upper motor neuron findings. However, you're also compressing the lower motor neurons that are exiting the spinal cord right at that level. So you're going to get lower motor neuron findings within the myotome that is innervated within that spinal cord segment. So you can have upper and lower motor neuron findings in the cervical cord compression lesion. However, you will not have any cranial nerve findings. So if you have a patient who you're suspicious of ALS, but they have bulbar findings, then it's not going to be located in the cervical cord. So spinal muscular atrophy, moving on to a different disorder, this is a lower motor neuron degenerative disease. So it is a genetic disorder. It's autosomal recessive. So patients will have a loss of the survival motor neuron 1 gene. So they have a loss of function mutation. There are multiple types denoting the severity and the age of onset. So we have these little mnemonics to try to remember what types they are. So type 1 is the most severe. These patients develop significant hypotonia pretty early. They can have these symptoms at birth or even just a few months after birth, so they won't be able to suckle. They'll have profound hypotonia. Type 2 is a little bit later onset, so after 6 months. So the first type is never sit, the second type is never walk, so they may develop some motor milestones, but they'll lose them progressively as the lower motor neurons degenerate. Type 3 is a little bit later onset, so maybe after toddler age or in early childhood. So these children, the mnemonic for this is never run, so it's a little bit later on in onset. And then type 4 actually is the best prognosis. This is in adolescent or early adulthood. These patients develop normally, but then as the weakness progresses, they may have to use a wheelchair, but often these patients have a normal lifespan. So the presentation really depends on survival motor neuron 2 gene copies. So the more copies of the 2 gene that you have, the better prognosis that you have. SMN2 is not the same as SMN1, so you will develop the disease. However, the more copies of this gene you have, the better off your motor neurons are for surviving over time. So when I was training, diagnosing a patient with spinal muscular atrophy was really often a death sentence. So these little kids or these babies that you'd see in the ICU with hypotonia, they'd be diagnosed with spinal muscular atrophy. They were looking at very quickly needing gastrostomy tubes as well as mechanical ventilation because they could not support life on their own. Now it's almost a completely different disease, which is really exciting. I mean, I didn't train that long ago. These drugs only came out. The one drug only came out a few years ago. There's a second drug coming out on the market, hopefully being approved by the FDA pretty quickly. But this is a really exciting time to be a neurologist because of the advances that are being seen in medical treatments. So nusinersen is the only FDA-approved treatment right now. This is an antisense oligonucleotide. So it actually helps splice the SMN2 gene so that it looks like the SMN1 gene. And so kids with SMA type 1 who may have needed a mechanical ventilator are now being able to eat and walk or sit up on their own without having any problems with ventilation. So it's really profound how much improvement these kids have made, or how many milestones these kids have able to develop even with a diagnosis of SMA. So Avixis 101 is actually a very, very exciting drug because it is actually replacing the SMN1 gene with a viral vector. So we can replace the faulty SMN1 gene. And so the patients who actually receive this in the clinical trials, they almost look normal. Some of these kids actually look normal because they got the medication before the onset of the disease. So very, very exciting time to be in neurology, right? So Charcot-Marie-Tooth disease is a hereditary motor and sensory neuropathy. So patients will have problems with both motor and sensory issues. So it's very, very slowly progressive. So typically, the symptoms will start to present in childhood, but they won't present to clinic until their late adolescence or early adulthood. It's a genetic disorder. Most of the time it's autosomal dominant. There's over 70 genes identified. However, the most common gene is the CMT type 1, or the most common disorder is CMT type 1, which is over 50% of cases. And the gene that's been identified that causes this disorder is PMP22, gene duplication. So this is important. It has been tested on step 1 before. So PMP22, remember that. And this is a demyelinating disorder. So it's not a problem with the nerve itself, but the problem with the myelination. CMT type 2 is the second most common, and this is an axonal problem. So the axons of the nerves actually degenerate. So the typical clinical presentation of Charcot-Marie-Tooth, like we said before in the previous slide, these people will have typically a normal childhood development. They may have some issues with balance or coordination as children, which may manifest in difficulty doing sports. But by the second decade, they usually will complain of weakness. On physical exam, they have weakness and sensory loss. However, what's interesting is that most patients don't complain of any problems with sensation. They mostly will just complain of the weakness. So on examination, you'll have decreased reflexes, and you can have atrophy in the muscles because it's a lower motor neuron disorder. They can have arthritic changes in the feet, so they'll have problems with high arches and hammer toes. So this is just a picture demonstrating the hammer toes and the high arches, or the pes cavus, of a patient with Charcot-Marie-Tooth disease. So diabetic neuropathy is a very common symptom of long-standing diabetes. It can happen in both type 1 and type 2 diabetes, and this is just damage to peripheral nerves. There are many different types of nerve damage syndromes that can occur with diabetes, but the most common is this symmetric, slowly progressive, sensory predominant neuropathy. So patients they'll complain of either numbness, so either a loss of sensation, or they'll complain of positive symptoms like burning, tingling, and aching. But on examination, these patients will actually have decreased sensation in all modalities, not only one modality. So they'll have vibration and pain and temperature. Typically, this is in a stocking glove distribution. So this is a length-dependent process. So the longest nerves are going to be the ones that are affected first, so the ones in the feet. And then as the disease progresses up the leg, then it'll start in the hands. So motor neuropathy can occur with diabetes. However, it's a later manifestation. When things are very, very bad, then they'll start to have some motor symptoms. So what you'll see is typically some toe weakness, and then they can eventually develop a foot drop if it goes long enough. So B12 deficiency can either be from poor absorption, like someone who has pernicious anemia, or if they have a primary problem with absorption because of a GI disease, or it can be from a vegan diet where patients do not eat any animal products whatsoever, and so they can get B12 deficiency that way. So the clinical picture, or the clinical syndrome, is called subacute combined degeneration, and this is because there's degeneration of the posterior columns, which include the vibration and the proprioception sensations. So you'll have sparing of pain and temperature. You also get degeneration of the lateral corticospinal tract. So you'll have weakness with upper and lower motor neuron findings. If this goes on long enough, patients can also develop cognitive changes, and B12 deficiency has also been associated with megaloblastic anemia. So these are some other things you may see in patients with long-standing B12 deficiency. So whenever you see someone who has this predominant vibratory and proprioception loss, there are a few things you should think of. So B12 deficiency is one, but also acquired copper deficiency can be one of them. So it looks similar to B12 deficiency. So whenever you're checking B12, it's good to check a copper level as well. So patients will have sensory loss with weakness, and that is also upper and lower motor neuron signs. And interestingly, this can be due to excessive zinc ingestion because zinc competes with copper for absorption in the GI tract. So there have been case reports of patients who use a lot of denture cream, which contains a lot of zinc. They'll just overuse it, change their dentures multiple times a day, and because of that excessive zinc ingestion, they don't have any copper, and so they get this myelopathy or the sensory loss. So vitamin E deficiency can also mimic B12 deficiency. You'll have the sensory loss with weakness. However, with vitamin E deficiency, you'll also involve the spinocerebellar pathways. So ataxia is a common manifestation. And ataxia just means poor coordination. So these patients will have balance problems and coordination issues with their hands. We'll talk a little bit more about ataxia when we get to the vestibular lectures. So there are other B vitamin deficiencies that you should be aware of when we talk about peripheral neuropathy. So B1 deficiency or thiamine deficiency, this causes several different syndromes, but dry beriberi is the one that's associated with this peripheral symmetric polyneuropathy. There's also muscle wasting that's involved, and it'll often involve the cranial nerve, so they'll have tongue and facial weakness as well. Thiamine deficiency is also associated with Wernicke-Korsakoff syndrome, which you'll learn about a little bit later, but it's also a neurological manifestation of B1 deficiency. B6 deficiency or toxicity can cause a symmetric peripheral neuropathy. This is something that I think a lot of providers are not aware of. That B6 toxicity can also cause neuropathy. So you've got to be really careful when asking or when telling your patients to take B6 or B supplements, B vitamin supplements, because they can actually become toxic and then develop this neuropathy from just getting too much B6 in their supplements. So alcohol can also cause symmetric peripheral sensory neuropathy. So this might be because a lot of alcoholics or people who abuse alcohol may not be taking in the nutrition that they need. They supplement alcohol instead of taking in nutrients, so they may have some of these other types of nutritional deficiencies. However, alcohol use is associated with neuropathy, so that should be a question that you ask your patients when they come in with neuropathy on examination. So last but not least, syphilis can cause a peripheral neuropathy. This is called tabes dorsalis, the syndrome that is associated with syphilitic infection of the nervous system. You get degeneration of the dorsal columns, so similar to B12, you have loss of proprioception and vibration that spares the pain and temperature pathway, so the spinothalamic tract is spared. The treatment for this is penicillin. We don't see this very frequently because of early detection and treatment with penicillin. However, it is something that you should be thinking about when you see someone who presents with this specific pattern of sensory loss.